Bismillahirrahmanirrahim. Today we will be studying the RCOG guideline about endometrial hyperplasia. The first thing which is written in this guideline in the introduction and background epidemiology part of this guideline is the definition of endometrial hyperplasia. Okay, all of you should know what is endometrial hyperplasia. Okay, endometrial hyperplasia basically is the proliferation of endometrium, and what is basically proliferated in the endometrium, that is basically the glands inside the endometrial area. Okay, so if we check the histology of endometrium, we will see that the gland to stromal ratio is increased. Okay, we have a lot of glands. Okay, the histology of this endometrium show that we have so many glandular tissues as compared to stromal tissues when we compared it with the proliferative endometrium. Okay, in proliferative endometrium, normally we have proliferative endometrium, but even in that stage, if we compare it with endometrial hyperplasia, we will see that the glandular to stromal ratio is very much increased. So that is basically endometrial hyperplasia. Now another point which is in the point 4 of this guideline is about the risk factors. Okay, if we study the RCOG guideline about endometrial hyperplasia, the point 4 is about the risk factor, and it is written that what are basically the risk factors for developing endometrial hyperplasia. Okay, and about this it's written that endometrial hyperplasia is so often associated with multiple identifiable risk factors, and assessment should aim to identify and monitor these risk factors. So what are those risk factors? First of all, increased BMI. Okay, the BMI of the patient from a normal person is increased. So whenever a patient comes with increased BMI, we have to keep this thing in our mind that this patient is at increased risk of endometrial hyperplasia as compared to other patients. So increased BMI is one of the risk factors. Now, the second risk factor is that of the excessive conversion of androgen into estrogen in the adipose tissue. Okay, if we check the adipose tissues, we will see that there is a proper biochemical processes going on. Okay, and what happens that we have androgen which is converted into estrogen as a result of aromatase inhibitor. Okay, aromatase inhibitor, okay, is a specific substance which converts androgen into estrogen. Okay, so whenever there is excessive conversion into estrogen in the adipose tissue, these are basically the adipose tissue. Okay, so what happens that this is again another risk factors for developing endometrial hyperplasia because it is related to the estrogen level. Okay, the third risk factor is that of the anovulation. Okay, this anovulation in the ovary is the result of several different factors. Okay, we are studying the risk factors of endometrial hyperplasia, but in turn that risk factor depends upon several other risk factors, like in case of the anovulation, which in which there is no ovo formation. Okay, that is the results of what? That may be the results of PCOS, or maybe as a result of perimenopausal stage. Okay, both can cause anovulation. Now there is another condition which is called the ovarian tumor. And which type of ovarian tumor? The granulosa cells ovarian tumor. Okay, the granulosa cells ovarian tumors are basically responsible for the endometrial hyperplasia. Okay, we have the uterus along with the endometrium. Okay, and we can see that there are ovaries on the side, and these ovaries have got multiple tumors, those are called the granulosa cell tumors. Okay, and these are responsible for endometrial hyperplasia as they produce excessive estrogen. And it is found that about 40% of the patients with granulosa cell tumors have endometrial hyperplasia. Fifth cause is that of effect of drugs. Okay, and among the drugs we include the estrogen containing HRT. Okay, HRT, especially the estrogen. Okay, and secondly, the tamoxifen has also been found to be associated with endometrial hyperplasia. Now, the fifth part of this guideline is about the classification. How would we classify this endometrial hyperplasia? Okay, basically it is said that we divide this endometrial hyperplasia into two types based upon the histological feature, that is endometrial hyperplasia with atypia. Okay, and second is endometrial hyperplasia without atypia. Okay, with atypia and without atypia. Okay, these are basically the main classification of WHO in 2014. And it is also written in the detail that in 1994 WHO basically classified into four main types. Those were simple hyperplasia, complex hyperplasia, simple hyperplasia with atypia, and complex hyperplasia with atypia. Now, the sixth point in RCOG guideline about endometrial hyperplasia is about diagnostic and surveillance method. Okay, diagnostic or surveillance method. Okay, which methods have been employed in the diagnosis and surveillance of endometrial hyperplasia? The first method is that of the histological examination of the tissue, which we have taken by doing endometrial biopsy. Okay, we can take endometrial biopsy in many different methods, by MVA method, by pipal methods, in major OT, in minor OT, as all of you know. Okay, so we take the endometrial sample and we check it histologically. That is one method. Okay, it requires histological examination of endometrial glands, and endometrial surveillance should include endometrial sampling, especially in the outpatient departments. Okay, but if it is difficult in outpatient department, we can do it in inpatient department as well. The main purpose is to get the biopsy sample for histological examination. And second method is about hysteroscopy, which has been discussed in the RCOG guideline about endometrial hyperplasia. Especially, it is written that we are trying to take endometrial samples, especially in the outpatient department, and it is quite difficult to obtain the sample. So what we need to do in that case, the preferred method is to perform the hysteroscopy. And if we check the indication of hysteroscopy, which I have also mentioned in one of my own videos, that there are specific indications of hysteroscopy. You cannot say that this patient needs hysteroscopy based upon your own wishes. There must be specific criteria fulfilled before offering the hysteroscopy, and that failure to collect the sample by outpatient department is also one of the indication for performing hysteroscopy. So hysteroscopy is another diagnostic modality in the patients having endometrial hyperplasia, especially when the outpatient sampling is non-diagnostic, or it is there is a failure to collect the outpatient collection of endometrial sample. And third diagnostic modality is that of the TVS. TVS is very much diagnostic, and it is relatively cost-effective economic method, because the ultrasound scan almost everywhere wherever there is gynecology setup. Okay, so if we do TVS, we can see that there is hyperechoic area and endometrial hyperplasia, along with certain glandular tissues indicating endometrial hyperplasia can be seen on the TVS. Okay, there is specific appearance on the TVS that indicate endometrial hyperplasia, and that is another diagnostic modality. It has role in diagnosing endometrial hyperplasia in pre and postmenopausal women. Okay, the fourth method is direct visualization. Okay, direct visualization using the same modality which I have explained, the hysteroscope, but this time this hysteroscope is not for hysteroscopic biopsy, which I have explained in part 2. Here we are doing direct visualization by using the hysteroscope. Okay, especially it is undertaken where the patient has been diagnosed with having polyps or discrete focal lesion. When we do ultrasound scan, we find that there is a suspicion of polyp, discrete follicle lesion, for focal lesion. Then we do the direct visualization for diagnostic purpose. Okay, so that is the fourth method. Now coming to the other modalities like CT, like MRI. Okay, their roles are questionable. Okay, there is insufficient evidence evaluating CT scan or MRI or biomarkers as aids in the management of endometrial hyperplasia, and their use is not routinely recommended. CT scan, MRI, and biomarkers, their roles are questionable. Now coming to the management of women with endometrial hyperplasia without Atpm. Okay, what should be the initial management of the woman with endometrial hyperplasia? The first thing should that be the counseling of the woman. Okay, we have to discuss with the woman about the prognosis of that endometrial hyperplasia, and it is said that those patients who are having endometrial hyperplasia without Atpm, in less than 5% of the cases, there is possibility of going into endometrial CA. Okay, less than 5% is having possibility to develop endometrial CA. Most of the cases of endometrial hyperplasia with atypia regress with time. Okay, so that is the counseling we have to tell about each and every aspect along with the prognosis, and that occurs in the period of 20 years. The second thing which we can do is to identify risk factors. Okay, identification of risk factor is also very important. Okay, what we can do, we can find out whether this patient is on HRT or whether this patient is obese, having increased BMI. Okay, we have to address these issues. We have to discuss with the woman that she needs to stop her HRT that might be responsible, and she needs to reduce her weight. Now we have to discuss the different treatment option with the patients, like observation alone plus follow-up. That can be one management option. Okay, that can be adopted as a one option to ensure the disease progression, but along with the identification of the risk factor. Observation and follow-up along with identification of risk factor, that can be one modality. But we have to tell the woman that along with this option, there can be another option, and that is the use of progesterone. Okay, the progesterone it comes in the form of POPs. Okay, like Ometril, Orgametril, and Togalutin. There are different brands available for progesterone only pill. We can tell the woman that treatment with the progesterone has higher disease regression as compared to observation alone. Okay, observation alone can be offered along with the follow-up and identification of the risk factors, but we have to counsel that POP has higher progression rate. Now, in what cases these progesterone only pills or progesterone treatment is considered? It is considered in the woman First of all, those who fail to respond to other treatment. Okay, fail to other treatment. And secondly, in the women who are having abnormal uterine bleeding. In both of these cases, we can offer the progesterone only treatment. Okay, the woman having abnormal uterine bleeding, then we can offer it. Okay, now come to the point 7.2, which is about the medical treatment. Okay, and the question is, what should be the first line medical treatment of endometrial hyperplasia without atypia? First of all, we can give progesterone. Those patients who are not willing for Mirena, we can offer them the 21 days pills, 21 days progesterone pills. The packet contains 21 days progesterone pill, but we have to ask her to take continuous. Okay, continuous POP, not 21 days with 70 years gap. We have to ask her to take continuous POP. Or we have another option, that is the Mirena. Okay, levonorgestrel intrauterine system, which also releases progesterone in a proper way, in a synchronized manner, and that is the that is having local effects. Okay, so both of these treatment modalities are very effective in achieving the regression of endometrial hyperplasia without atypia. Now, if the question is asked about the first line option, okay, the first line option, would that be Mirena? Okay, Mirena, because of different reasons. Okay, about this it's written that Mirena has got higher regression rate. Okay, it causes regression more as compared to progesterone, continuous progesterone, oral progesterone. Okay, secondly, it has got more favorable bleeding profile, increased regression rate, and third is that is fewer side effect. Okay, because of fewer side effects, increased regression rates, and more favorable bleeding profile, this Mirena is considered to be as the first line treatment option. Now the question is about the continuous progesterone as well. We have discussed that Mirena is the first line option. We have discussed this. Now come to discuss the continuous progesterone. What type of progesterone combinations we should use in this case? About this it's written that the most commonly used or should be or preferable are those of medroxyprogesterone acetate, progesterone acetate, and second is that of the norethestérone. Okay, medroxyprogesterone acetate usually come in the form of Depo-Provera. 5 mg is the usual 1 tablet dose, and the dose recommended in RCOG guideline is 10 to 20 mg per day. Norethestérone, like Primeluch, and the dose recommended according to the guideline is 10 to 15 milligram per day. Now, there are several gynecologists who use the cyclical progesterone. Okay, the role of cyclical progesterone is questionable. Okay, and it is written in the guideline that this cyclical progesterone should not be used because when we compare it with Mirena and we compare it with the continuous progesterone only pill, it has got lesser rate of regression. It is not as effective as continuous progesterone is, so the cyclical progesterone should not be used. Now come to the duration of treatment and follow-up of endometrial hyperplasia without atypia. About this it's written that both progesterone, oral progesterone, and levonorgestrel should be used for at least 6 months. Okay, 6 months in order to induce histological regression of endometrial hyperplasia without the atypia. Okay, that is for both progesterone plus Mirena. Okay, now for the Mirena levonorgestrel intrauterine system, it is written that we can continue it for 5 years, but there are certain conditions for it. First of all, if it is tolerated by the woman. Secondly, if the bleeding has been elevated, and if the fertility is not required. Fertility is not required, there are no adverse effect, and the it alleviates the abnormal uterine bleeding pattern, that it can be continued for the period of 5 years. Along with discussing the treatment option and for how long we need to continue the treatment, it's very important to know about the endometrial surveillance as well. Okay, for how long should this treatment be continued? Okay, it's written that we have discussed for how long. It's very important that we take endometrial biopsy by outpatient or inpatient, whatever the method is preferable for doing the endometrial surveillance. That is also very important. And endometrial surveillance should be arranged at the minimum of 6 monthly. Now the question arises after how much time we should do endometrial sampling. It should be 6 monthly. Okay, we have identified the endometrial hyperplasia in the patient. For 6 months we have to give progesterone and Mirena, and those patients who are not having adverse effect and they are not willing to have pregnancy, then they can continue it for 5 years. We have to do endometrial biopsy, DNC, or whatever the method for endometrial sampling, and it should be arranged at minimum 6 monthly interval, although the we can review the schedules based upon the woman's clinical condition. And at least 2 consecutive 6 monthly negative biopsies should be obtained prior to discharge. Before we discharge the patient from further follow-up, because there is possibility that this endometrial hyperplasia without Atpm regresses. Only in less than 5% of the cases there is chance of endometrial hyperplasia. Before we discharge these patients, there must be 2 samples, 2 endometrial biopsy samples, which should be negative. Okay, these should be negative before we discharge the patient. Okay, these should be negative, and then we can discharge the patient. But although we discharge the patient, we have to also counsel the woman. We have to tell the woman to seek further advice. Okay, seek further advice in case if she notices symptoms again, notices abnormal uterine bleeding, because there is possibility of recurrence of endometrial hyperplasia as well. And another important thing for high risk group of patient is written in the guideline. High risk patients, okay, high risk are those having increased BMI, okay, those who are treated with the progesterone pills or whatever, and they have got 2 endometrial biopsy negative reports, but they are included in the high risk. Okay, so to every patient we will tell her that she should seek medical advice whenever she develops symptoms, but to these high risk group we have to arrange annual biopsy as well, annual biopsy sample, because these are high risk. We shouldn't discharge them completely. Now come to the surgical treatment of the patient with endometrial hyperplasia without Atpm. Okay, sometimes the patients with endometrial hyperplasia are so much tired, so much depressed of their endometrial bleeding, abnormal bleeding, that they opt for the surgical management. They usually want the hysterectomy. But the thing is that in case of endometrial hyperplasia without Atpm, usually the progesterone treatment in the form of pills or in the form of Mirena is very much effective. It is found to be very much effective, and a Mirena should be used as a first line treatment. Progesterone treatment should also be used if she wants it, and this hysterectomy shouldn't be considered as a first line treatment because of morbidity associated with the surgery. Okay, so I'm drawing the picture of hysterectomy. Okay, we are removing the uterus, we are considering the option of hysterectomy. But we shouldn't offer it to each and every patient with endometrial hyperplasia, especially those with atypia. We shouldn't consider in each and every case. But yes, in certain group of patients, we can offer hysterectomy. Okay, offer hysterectomy in which patient? Okay, so we have to offer surgical treatment when there is progression to atypical hyperplasia during follow-up, where there is no histological regression. Okay, and when there is relapse of endometrial hyperplasia after treatment. Okay, there is progression of symptoms, there is no histological regression, and there is of endometrial hyperplasia, relapse of endometrial hyperplasia even after treatment. Certain group of women are having persistent bleeding, okay, and there is another group of women who decline to undergo endometrial surveillance, So all these groups of women should have, or we can offer in them, the choice of hysterectomy. So there is 5 main indications for a hysterectomy in patients with endometrial hyperplasia without atypia. But about the perimenopausal woman, it's written, okay, we have perimenopausal woman. We can offer the choice of BASO as well. If these criteria are fulfilled in them, then, and we have planned for hysterectomy, then we should offer TH plus BSO in them in perimenopausal women. Okay, we have to remove ovary in them as well, because in perimenopausal age, definitely the function of the ovary comes to decline. And in a premenopausal woman, there should be an individualized approach. Okay, we have to discuss the different options with the woman, option of HRT and a different thing if she opts for BSO as well. But the preferred choice is TH plus BSO in them as well, in order to reduce the risk of the ovarian malignancy in them as well. Now this hysterectomy can be done in the different ways. It can be the open surgery, or it can be the laparoscopic surgery as well. The laparoscopic hysterectomy as well, that depends upon the choice of the woman. But if the choice is asked from the doctor, the preferred method of removal of the uterus would that be the laparoscopic method. Okay, laparoscopic hysterectomy is preferred because of shorter hospital stay, because of less post-operative pain and quicker recovery. This laparoscopic approach is preferred. Now coming to the choice of endometrial ablation, okay, that is also questionable, one of the treatment modality about which several questions arose in the past. But RCOG guideline says that this endometrial ablation should not be recommended for the treatment of endometrial hyperplasia, because it has 2 drawbacks. First of all, there is complete and persistent endometrial destruction, cannot be ensured, but complete and persistent destruction cannot be ensured. Secondly, there is a risk of intrauterine adhesion formation, which may preclude the future endometrial histological surveillance. So that is the reason that we do not offer this endometrial ablation. Now come to the management of endometrial hyperplasia with atypia. Okay, in them we have to go for hysterectomy. Okay, hysterectomy is the treatment of choice in them, because atypia shows malignancy. Okay, they should undergo total abdominal hysterectomy because of the risk of underlying malignancy or progression to cancer. Okay, and what type of hysterectomy? The laparoscopic. The laparoscopic approach is preferred to an abdominal approach, as it is associated with a shorter hospital stay and less post-operative pain and quicker recovery. Okay, now another thing which is discussed in this guideline is about the frozen section. Okay, about the frozen section analysis, it is written that there has no benefit in diagnosing, okay, in diagnosing the final pathology of women with endometrial hyperplasia or Atpm. Neither is the role of any lymphadenectomy in the while performing the procedure. Okay, and another thing is that those women, the postmenopausal women with atypia, should be offered BSO as well. TAH plus BSO should be offered in these women along with the TAH. Okay, these are for postmenopausal women, and for perimenopausal, for this is for the postmenopausal women. For postmenopausal women, we have to offer TH plus BSO, and for perimenopausal women, we have to discuss with them. Okay, for perimenopausal women, the choice is that of counseling. Okay, the decision to remove the ovaries should be individualized. However, the bilateral salpingo-oophorectomy should be considered, as this may reduce the risk of future ovarian malignancy. Okay, and endometrial ablation is not recommended because, again, there is a question of endometrial ablation. Okay, that is also not recommended here because it is not found to be very effective. Endometrial ablation is not recommended because complete and persistent endometrial destruction cannot be ensured, and there is also risk of intrauterine adhesion formation with this procedure, with endometrial ablation. Okay, there's risk of adhesion formation as well. There are certain group of women who are having endometrial hyperplasia with atypia, and they are wishing to preserve their fertility. So what we have to do, we should counsel them about the risk of underlying malignancy and subsequent progression to endometrial cancer. Okay, we have to counsel them. Okay, they are wishing to preserve their fertility, so we can't offer hysterectomy in them, but we have to counsel them that there is risk of progression to endometrial cancer. Okay, in them there is the option of pre-treatment investigation. Okay, that should be aimed to rule out invasive endometrial cancer or coexisting ovarian cancer as well. Another thing is that the histology should be done. Histology, imaging, and tumor marker results should be reviewed by these things should be reviewed in MDT, multidisciplinary team meeting, and a further plan for the management and ongoing endometrial surveillance is formulated in multidisciplinary team. Okay, and another thing is that first line treatment. What should be the first line treatment? The first line treatment in them should be levonorgestrel intrauterine system should be recommended with oral progesterone. Okay, that should be the first line, and second is that of the oral progesterone as a second line treatment. Once fertility is no longer required, hysterectomy should be offered in view of high risk of disease relapse. Okay, if fertility is not required now, no fertility required, then go for the option of hysterectomy. Now we have planned that yes, we are not doing the hysterectomy for these patients with endometrial hyperplasia with Atp. So how would we do follow-up? Okay, the follow-up by doing the endometrial biopsy or endometrial surveillance is done on 3 monthly basis in such women. After every 3 months we have to check, we have to do endometrial sampling until two negative results are obtained. Okay, two negative results are obtained after 3 monthly biopsy. So what we have to do after two negative results? Should we leave them? No, we shouldn't leave them, as they have got endometrial hyperplasia with atypia. Once we have to continue surveillance. Two negative results are obtained by 3 monthly biopsy. Now we have to make a long-term follow-up, and that is 6 to 12 monthly endometrial surveillance. Till how much time? Till hysterectomy is done. And definitely if any sample shows again endometrial hyperplasia with atypia, then we have to discuss the choices with the woman and preferably go for hysterectomy because of increased risk of endometrial CA. Okay, and now there are certain groups of women who wish to conceive. How should the endometrial hyperplasia be managed in a woman wishing to conceive? About this, the prerequisite is that there should be disease regression. Okay, disease regression should be achieved on at least one endometrial sample before women attempt to conceive. Secondly, the women with endometrial hyperplasia who wish to conceive should be referred to fertility specialist. Refer to fertility specialist. Okay, another thing is that assisted reproductive technique may be considered, as the live birth rate is higher and it may prevent relapse compared to the women who attempt natural conception. Okay, and another thing is that prior to assisted reproduction, regression of endometrial hyperplasia should be achieved, as this is associated with higher implantation and clinical pregnancy rate. Okay, so prior to ART, the prerequisite is that there must be endometrial regression. Now the 10th point is about HRT and endometrial hyperplasia. Okay, the thing is that systemic estrogen only. Okay, we may have certain estrogen only HRT. Okay, these should not be used. Estrogen only HRT should not be used because that can cause endometrial hyperplasia. And another thing is that women should be told that whenever she experiences certain unscheduled bleeding, then she should contact her clinician as soon as possible. Okay, there might be certain women who are having unscheduled bleeding whenever they are on HRT, then they should contact, okay, go to clinician in that case. Okay, now there are a certain group of women who are taking sequential HRT. Okay, the women on the sequential HRT, as we prescribe to most of the women who wish to continue HRT, should be advised to change to continuous HRT. Okay, who want to continue HRT, they should be asked to change it to continuous HRT, but not the estrogen containing. Okay, so the idea is basically the same as we prescribe the endometrial the pills for endometrial hyperplasia. We stopped the sequential POP. Now we are stopping the sequential HRT. We are asking her to take the continuous HRT. Okay, and another option is that of the Mirena, levonorgestrel intra uterine system. Mirena can be offered to them. Subsequent management should be described, okay, and should be discussed with the woman. Okay, women with endometrial hyperplasia taking continuous combined preparation who wish to continue HRT should have their need to continuous HRT review and discuss the limitation. Okay, we also have to discuss with the woman. Okay, discuss the limitation of the available evidence regarding the optimal progesterone regimens. Okay, and consider levonorgestrel intrauterine system as a source of progesterone replacement, and subsequent management should be discussed with the woman. Now let us discuss the the management of women with endometrial hyperplasia and breast cancer. Okay, there are certain group of women having breast cancer, and what they do for the breast cancer. Okay, for the breast cancer, they are taking certain sort of medications. So what we have to discuss the risk of endometrial hyperplasia in them. Okay, especially the women who are on aromatase inhibitor like anastrozole, axastine, and letrozole. These women are at increased risk of developing endometrial cancer as well. Okay, the breast cancer patients who are taking the treatment for the breast cancer, they are at the risk of developing endometrial hyperplasia. Okay, so we have to counsel these women that whenever they experience certain unscheduled bleeding, then they should contact their clinician. Now, another point is about the tamoxifen. Tamoxifen is a specific drug which is taken by the patient with the breast seal. Okay, and it usually come in the dose of 20 milligram tablet. Okay, so the patient is on tamoxifen. Whenever the patient comes, we take the proper history. So the question arises, should the woman on tamoxifen be treated with prophylactic progesterone therapy? Okay, progesterone therapy. Should we prescribe the prophylactic progesterone therapy in them? That is a question. Okay, about that is written that there is evidence that levonorgestrel intrauterine system prevents the polyp formation. Okay, so inside the uterus we have put the Mirena, and that prevents the polyp formation. Okay, and that it reduces the incidence of endometrial hyperplasia in the woman taking tamoxifen. Okay, so those patients who are on tamoxifen, this Mirena is the preferred choice. Okay, not only it prevents the endometrial hyperplasia but also prevents the polyp formation. The effect of levonorgestrel on the breast cancer recurrence rate remains uncertain, so routine use is not recommended. Okay, so the effect on the whole is uncertain. We don't know about its overall effect of this Mirena, but yes, it can be offered as a choice as compared to that of the progesterone pills therapy. This is also progesterone therapy. So here we discuss the prophylactic option of progesterone therapy. Woman is on tamoxifen for the breast cancer. Okay, and she is taking tamoxifen. We are considering the choice of progesterone prophylactic therapy. Now there is another group of women who actually develops the breast cancer. So they are on tamoxifen. Okay, they also develop the endometrial hyperplasia. Okay, so actually they are patient of endometrial hyperplasia now. Okay, in that woman, it is said that the need for this tamoxifen, okay, whether to give or not. That depends upon, first of all, the histological classification. Okay, endometrial hyperplasia has to be classified histologically by histologists. That depends upon histological classification and the woman's oncologist as well. We have to discuss this thing with the woman oncologist, that what type of breast cancer has she got, can we stop it for a while or not. That depends upon the overall case scenario and after discussion with the patient as well as the woman oncologist. Now coming to the last point, endometrial hyperplasia in endometrial polyp. Endometrial hyperplasia okay, about this there should be a specific consideration. Okay, we found that there is endometrial polyps. Okay, maybe on doing speculum examination, maybe on ultrasound, or maybe on hysteroscopy, by using whatever investigation, whatever diagnostic modality, we found that there is endometrial polyp. Okay, and there is suspicion of endometrial hyperplasia in that. So what happened, what we have to do, we have to complete this polyp, completely remove this polyp. Okay, remove. Okay, this is basically the polyp. We have to remove this polyp surgically by using any method. Okay, and then send that removed sample for histopathology. Okay, for histopathology we have to send it, and further management will be based upon the report. The histopathology report will show the further management in such patients. So that is about the RCOG guideline about endometrial hyperplasia. Now let us discuss the very important table, which definitely I cannot draw, so I'm putting my book in front of you. Now let us discuss this Appendix 2, algorithm for the management of endometrial hyperplasia. Okay, so we have divided according to WHO classification that endometrial hyperplasia based upon histopathology results into two main types: endometrial hyperplasia without atypia and atypical endometrial hyperplasia. Okay, in atypical endometrial hyperplasia, definitely we have to go for total abdominal hysterectomy plus BSO. In the postmenopausal woman, straight away go for TH plus BSO. In perimenopausal woman, discuss the options, and if she is willing for TH and BSO, then go for that. If she is not willing, then discuss the options of Mirena for the limited period of the time, along with endometrial surveillance. Okay, now what we have to do in endometrial hyperplasia without atypia, we cannot go for hysterectomy straight away in that. What we have to do, we have to address the risk factor observation. We have to check, have they got any risk factors, like we have discussed before, like have they got increased BMI, have they got are they on any drugs like Tamoxifen, and have they got PCOS, or are they in perimenopausal stage or not, and there are different risk factors which we have discussed. Okay, so in them the first line of management would that be the Mirena. Mirena is the first treatment of choice, first management of the choice, levonorgestrel intrauterine system, and oral progesterone, the continuous oral progesterone, would be the second treatment. And also it's very important, if she is on sequential oral progesterone, change that to the continuous progesterone. Okay, now we have to check, okay, that we have to do endometrial surveillance, and also those patients who are having atypical endometrial hyperplasia and they want to preserve their fertility is required, or surgery is contraindicated, then we have to go for these options like levonorgestrel as a first treatment of choice after assessing the risk factor, and progesterone as a second treatment option. Okay, and then in both cases we have to do endometrial surveillance. Okay, in case of the endometrial hyperplasia without atypia, then we have to do 6 month surveillance. Atypical hyperplasia, then 3 monthly surveillance. Okay, and then we have to check what are the results. Okay, there are regression of symptoms. Okay, the symptoms get regressed. Okay, let's come to this point. Review treatment. Levonorgestrel intrauterine system continues for 5 years and oral progesterone stop after 6 months and TH plus BSO if ongoing abnormal uterine bleeding. If she is opting for the oral progesterone, then 6 monthly treatment, and for levonorgestrel intrauterine system for 5 years if she is not willing to have the children. Okay, then we have to arrange the further follow-up in them. Okay, in case of the endometrial hyperplasia, another thing is that endometrial hyperplasia without Atypical BMI is less than 35 and more than 2 consecutive negative biopsy, then endometrial hyperplasia at 6 monthly interval and then discharge. Okay, but if she is having risk factor, this is what we discussed in the guideline as well when we were discussing the detail, that if she is having the risk factor BMI more than 35 or treated with the oral progesterone, then in that case, if 2 consecutive negative, then endometrial hyperplasia at 6 monthly interval and thereafter annual endometrial endometrial biopsy and review. Okay, so if she is not having risk factor, okay, then 2 consecutive negative biopsy, we can discharge her because she is not having other risk factor. But if she is having risk factor like increased BMI, we are getting 2 negative biopsy results, even then we have to arrange the annual biopsy plan as well. Now coming to atypical hyperplasia, what we have to do in that case. In atypical hyperplasia, if we have 2 consecutive negative biopsy at 3 monthly interval, then 6 monthly and endometrial hyperplasia and review. Okay, relapse, the symptoms relapse, then we have to consider DTH plus BSO. Okay, now come to the point of persistence. If there are persistence of endometrial hyperplasia, what we have to do. Endometrial hyperplasia without atypia, start treatment if the observations fail. Okay, advise hysterectomy plus BSO if persistent after 12 months of the medical treatment. And in atypical hyperplasia, advise TH plus BSO. Okay. So in endometrial hyperplasia, we have to consider 12 months treatment before we offer her TH plus BSO. But if she is having the atypical hyperplasia, then straight away go for the TH plus BSO. Now another thing about the progression, that was persistent, and this progression mean it has progressed further. Okay, we have to review the treatment. In atypical hyperplasia, go for TH plus BSO. In endometrial hyperplasia, manage according to the local cancer guideline. In endometrial cancer, okay, in endometrial cancer, local according to the local guideline. Okay, and we also have to arrange the follow-up when we okay, in both cases, also in this case and also in that case. Okay, TH and BSO has been done, and when we do the follow-up and no endometrial cancer is found, then we review at 6 weeks and then discharge. Okay, and when endometrial cancer is found, then manage according to the local cancer guideline. So that is all about the appendix 2 of this guideline, which is really very important. Thank you so much for your patience.